I'm Patrick Ford. I'm a thoracic oncologist at Johns Hopkins in Baltimore, and I'm glad to be here talking with a colleague of mine, Dr. Joshua Royce, who's a thoracic medical oncologist at Georgetown University in Washington, D.C. So today, Josh, I thought we'd talk a little bit about recent developments in the systemic management of mesothelioma. And in particular, we've seen some major developments in the last few months in terms of a new approval for the first time in a long time for patients with mesothelioma. Perhaps you can kick us off by giving your thoughts on this new treatment option for mesothelioma.
Sure. Thank you, Dr. Ford. I'm happy to be here to talk about this exciting research in a field that is long overdue for some. So to what you're referring, Checkmate 743, the phase 3 study comparing combination immunotherapy with nivolumab and ipilimumab to frontline platinum chemotherapy in treatment-naive patients recently resulted and was presented at the Presidential Symposium of World Lung earlier this year, finding improvement, both meaningful and statistically significant improvement in overall survival with the immunotherapy combination. I think this is very exciting. I think this is definitely beginning a transformation in the treatment of these patients that, again, is long overdue. I think in particular it's exciting for our patients with non-epithelioid histology. So as we discussed in one of our previous modules, this overall survival benefit did appear to be driven by patients with non-epithelioid histology, a population that has historically been resistant to chemotherapy. And so I think that in particular is a very exciting population that can already transform the treatment of those patients with that particular histology.
Yeah, I think that's one of the remarkable findings in this study, Josh, in that I think historically we may not think about it, but for non-epithelioid patients with mesothelioma, the prognosis has been pretty poor. With a median survival of less than a year in most cases. And indeed, in the control arm in this study, Checkmate 743, I believe the median survival for non-epithelioid patients was about 8 months. But there was a very dramatic increase in that survival for patients treated with immunotherapy. Do we have any thoughts as to why that might be, this apparent difference in outcome by histology?
Well, it's a good question. I think one that definitely warrants ongoing research. I think one looming question and tantalizing question is this related to PD-L1 expression? You know, in prior single-arm and smaller studies, the data has been mixed whether PD-L1 may be predictive of benefit, and it does appear that sarcomatoid histology or non-epithelioid histology does have a higher frequency of PD-L1 expression. But I think it's a real question of chicken and egg here. You know, are we seeing a better response, potentially better response in PD-L1 positive because that's primarily the sarcomatoid histology, where we saw a greater magnitude of benefit, a greater magnitude of benefit in this study, or does PD-L1 predictive in some capacity? And I think that remains to be seen.
Mm-hmm. And I think, so I guess we keep in mind as well that there was no loss of benefit for epithelioid patients, similar outcomes in many ways for those patients who had epithelioid histology. So the combination immune checkpoint blockade remains an option as a first-line treatment for patients with epithelioid disease. To talk a little bit about other, I think those are very dramatic findings. The first time in 16 years, I think we've had a new positive phase 3 trial for mesothelioma, and I think that's exciting for everyone and for the mesothelioma community. There are other studies ongoing looking at combination treatments for mesothelioma in the first-line setting, in particular the combination of chemotherapy with immunotherapy. We're seeing, for example, here in the United States, there's a study combining a platinum doublet with durvalumab. In Canada, platinum doublet with pembrolizumab. And in Europe, the 4-drug combination of platinum doublet with bevacizumab and atezolizumab. So I think we'll be eagerly awaiting those findings. Have you any thoughts, Josh, as to how we may in the future be able to decide between these treatments for patients, and what kind of selection criteria we might use?
Yeah, no, I think that's a great question. I think that, I don't think we're going to be able to rely on PD-L1 expression, in all honesty. I think initially histology will hopefully help to drive the decision. With non-epithelioid right now, seeing a dramatic benefit with the nivolumab-ipilimumab combination. Plus, we know that chemotherapy, this is not a chemotherapy-responsive disease, the non-epithelioid histology. So I think knowing that, it's going to be interesting to see if a non-epithelioid histology sees a benefit with chemotherapy plus immunotherapy in a cross-trial comparison way compared to combination immunotherapy. So I think that initially, looking at immunotherapy, chemotherapy combination, in particular in epithelioid, maybe immunotherapy combinations in non-epithelioid, and then obviously ongoing biomarker research to better distill down who's most likely to respond.
Sure. And I think another element, particularly in mesothelioma, where the patient population tends to be older, not always, but the median age is usually over 65. We are cognizant of toxicity from treatments, and there may be particular reasons, for example, that immunotherapy is a good choice for some patients and may not be as good a choice, for example, a patient who has an active autoimmune condition. The combination of ipilimumab and nivolumab may not be the best choice in that case, whereas somebody who has a reason for which chemotherapy would not be a good choice, for example, a significant renal impairment or neuropathy, then the immunotherapy could be a good choice in those cases. So I think it'll be on a patient-by-patient basis and discussing the pros and cons of both immunotherapy combinations and also chemotherapy, or perhaps in the future chemotherapy in combination with immunotherapy.
Yes, I agree. I was going to add, I think either way, I think incorporating immunotherapy, though, if it's going to be incorporated for the treatment of patients, it should be done in the frontline setting. I think like other tumor types, we definitely see a drop-off in response and durability of response in the subsequent line setting. So I think if you're going to incorporate immunotherapy into the treatment of mesothelioma patients, it's best done in the frontline setting, at least as far as what we have available right now.
Yeah, I think we saw that in the PROMISE Meso trial, which was recently published, which compared to pembrolizumab, the anti-PD-1 antibody, with standard of care second line or third line single agent chemotherapy, and there was no benefit in that study for pembrolizumab. Now, I think people are still searching because there definitely are some patients who appear to have clinical benefit in the second line treatment with single agent PD-1 or PD-L1 blockade. But that randomized phase 2-3 study did not show a benefit. So I think, as you say, Josh, I think the first line setting is where these combinations are moving, and hopefully where we'll continue to derive benefit for these patients. So I hope that everyone has enjoyed our session of videos on mesothelioma and the exciting developments in the last year in particular. And we'll finish up from our perspective, and thank you all for your attention.